Good morning. So today's topic is on case control study. Myself, Dr. Niveta. So today's class synopsis is definition of epidemiology and study designs in epidemiological field and analytic what will explain in detail about what is analytical epidemiology and steps in conducting the case control study and what are the bias we'll see in case control and their advantages and disadvantages. So today's SLO is to define the epidemiology, to describe the study designs in epidemiology and explain how to conduct case control study. So coming to the definition of epidemiology is a study of the distribution and determinants of health related states or events in specified population and the application of the study to control the health problems. So here the main point is the distribution. So distribution of the disease in terms of frequencies and determinants of health related states. We will have some determinants related to the health also. We will done in a specified geographical population, and based on that we have to apply these results to control the spread of the disease. So coming to the study designs in the epidemiological studies, the basically will have the descriptive and analytical. So today's topic is on case control, which comes under the analytical. In analytical also will have the observational and intervention. So here the basic difference between the descriptive is nothing but will express everything in terms of frequency and we won't analyze anything. We'll just present whatever it is there. Whereas in analytical, we'll test the hypothesis. Whereas in the observational, we won't intervene the population. So in case control also this applies. Whereas the interventional studies will do some intervention among the controlled population. So what is analytical epidemiology is nothing but will test a specific hypothesis, must begin with a clearly formulated hypothesis and it should be quantitative and specific. And this analytical epidemiology must predict the relationship of a risk factor to a disease. And in this mainly it will tell us whether there is statistically association is there or not between the disease and the suspected risk factor. And if it is there, we have to find the strength of the association. Coming to the three distinct features of a case control is nothing but the main difference is that exposure and the disease has occurred before the start of the study, whereas in in cohort study where the disease will progress after the start and we will see for certain period, and here we'll proceed backwards in the case control, like after the disease has occurred will see the patients backwards or will go from the effect to cause. Nothing but effect is the disease to the cause of the risk factor, and we are using the control group as a comparison group which don't have the disease but will have the risk factors. And here in case control we'll have two population, that is the cases and the control, and here the unit of study is the individual. So from this diagram here both the groups have the one is the cancer patient and one is non-cancer patient, but we are tracing back and we are seeing whether there is risk factor is present or not by taking the history, and we'll go to the conclusion, that is the backward class or retrospective study, which is the case control. So the basic steps here are selection of cases and controls, next by matching and by the measurement of exposure. The last step is the analysis and the interpretation. So coming to the selection of cases and control, in the selection of cases, so we have to have the predefined diagnostic criteria for a certain disease and we have to mention the eligibility criteria, so in order to prevent the error in the study. And where we can select these cases are from the hospitals and from the general population, where the hospital is the most convenient and most easy and inexpensive. And how to select the controls? So the controls must be free from the disease but should be similar to all the aspects except the absence of the disease should be there, because if we select the same means we won't get the similar, we won't able to distinguish the difference between the cases and the control, but rest of the factors should be seen. and it should match the control similar to that of the cases also, and it should be selected from the same population. If we took from the other population, this may result in bias, or we also known as call it as errors. So where we can find those controls the same as cases, we have hospital, general population, and apart from that we have the relatives, neighborhood also. Step is the matching. So nothing but we have to match the similar controls with those of the cases except the presence of the disease. So here matching is done to prevent the bias that will occur in the case control study. So because certain factors may influence the outcome of the disease, and if not properly matched may confound the results. And coming to the next step is the measurement of exposure. So after matching, how we can able to collect those data from the patient is by interview or questionnaire, or studying past records, that is from the hospital, or employment records, because we are doing a retrospective study. In order to take the data, we usually have the hospitals or employment records. And coming to the last step is the analysis part. So in this, after the data collection, we have to do the exposure rates, and we have to find out the estimation of the risk. So here exposure rate is nothing but the frequency of exposure to a suspected factor in a disease and non-disease group should be made. For example, if we are doing a case control study between the association between the smoking and the lung cancer. So we are taking a patients, two group patients with lung cancer and without the lung cancer, and we are seeing whether they are having the history of smoking or not. So in this, first we have to do the 2 by 2 table where the columns represents the cases and the control. In the row you have to in the row it will represents the exposure is present or not, and you have to name it as A, B, C and D. So in this cases, the total cases are 35. Among that 33 were smokers, and in the control group 82 were control, and among that 55 were smokers, that is smoking less than 5 cigarettes per day. So we have to draw a 2 by 2 table or contingency table. So coming to the exposure rates, we have to calculate exposure rates for cases and controls separately. For the cases, the formula is A by A plus C, is nothing but exposure among cases by total number of cases. So the percentage is 94% having the exposure of smoking among the cases, and in the control 76%. So next, estimation of the risk. How we can identify by doing a formula known as the odds ratio. It is helpful in identifying the association is present or not. So odds ratio is nothing but a cross product ratio is we can obtain from the 2 by 2 table. So it will gives the measure of association, strength of association between the risk factor and the outcome. So when we will do this odds ratio or calculate odds ratio means when the disease should be rare, and the case must be representative of those with the disease, and the control should be similar to the cases but without the disease. So here how we are calculating is nothing but odds ratio formula is AD by BC, or by the cross product means nothing but AD by BC. So here the formula also, odds of that cases was exposed by odds that a control was exposed. So among the cases, among the exposed cases by control. So here by applying these values, we obtain 8.1 as odds ratio. So how we can interpret these odds ratio? So here 8.1 means here smokers are having a risk of developing lung cancer 8.1 times than that of the non-smokers. Here one of the drawback is we can't able to calculate the incidence of the disease. So here we can tell odds, that is the probability of getting the chances of getting the disease. So one of the major error or bias found in the case control study may be due to the memory or recall bias. Nothing but we are collecting a data from a retrospective format, so there will be lack in information, so that is we call as memory or recall bias. And coming to the selection bias and interviewer bias is and Bergensonian bias. So here selection bias, if the if the research people know who are cases and control, they may give more importance to the cases than in controls. And among that hospital and general population selection also, if we did some error, it will result in the selection bias. And coming to the interviewer bias, same as the selection, where the researchers gave more importance to the case people than the control. So it will result in some biases or error. And Bergensonian bias is also known as the hospital based bias, that is the different hospitals have different rate of admission. If we are taking at one particular hospital, the rate of admission will differ from the another hospitals. So how we can prevent these bias is by using the blinding method. So in this blinding also, we will have the single, double blind and triple blind also. So coming to the advantages in the case control is easy to carry out, because we don't need to follow up for a certain duration. If we select the people, we are able to collect the data in a retrospective. Next is the rapid, and it is less expensive compared to the control cohort study. Next, it requires few subjects because it's a rare disease. We will have only a few subjects to be tested, and we will have compared to the cohort study. And there is no risk to the subject because we are not doing any intervention. We are just following up the patients. And the next advantage is allow the study of several different etiological factors. How? Because we are taking a patients with a rare disease, and we are doing backwards, and we are able to collect the different data on the risk factors, so that we can able to identify what are the different etiological factors. And the next is risk factors can be identified. And the next one important is no attrition problems or nothing but the loss to follow up. Next, here ethical problems also is minimal. And the last is the major uses in the rare diseases, because we can't able to do in a cohort which requires a more sample, and we have to follow up for a longer period, longer duration. And coming to the disadvantage, here is the problem is the bias, that is the recall bias, Bergensonian selection and interviewer bias, so that we can able to control by doing the blinding. And here next one of the disadvantages, selection of control group may be very difficult, because we have to wait for a longer period to get the matched control group similar to that of the cases. And here the incidence cannot be measured, because the incidence is number of new cases we have to collect, where we don't have the new cases. We are getting the patients who are already having the disease. And the next one is not useful for evaluation of therapy and the prophylaxis, because we are not doing any intervention or any other therapy. And the last is the representative of the case and the control should be similar. Sometimes it may be very difficult. These are my references. Thank you.